All right, we'll get started. We're passing the attendance sheet around, so if you guys could all look for it and sign in, we're glad that you're joining us. And we're grateful for you guys joining from distant sites. Right now the slides are up, so we're not looking at Sanford Braithwaite or Avera Pharmacy Conference Room. We're glad that you guys join us for our regular monthly grand rounds. So let me get started. Today we have Dr. Marcio Griebeler joining us as our local content expert and clinician educator who's going to teach us about obesity and obesity-related comorbidities. Briefly, Marcio got his MD in Brazil decade and a half ago. You were a primary care physician for a number of years in Brazil before you came to the States. And then you did a residency here at University of Miami in Florida. Finishing your residency in Miami, Mayo Clinic Rochester grabbed you, and Dr. Griebeler did his clinical fellowship in endocrinology and metabolic diseases, Mayo Clinic Rochester. And then we were fortunate enough to have you come here as a clinician leader at Sanford Health in endocrinology in 2014, 2015, also as an assistant professor of medicine here at University of South Dakota. You've been an assistant professor for a number of years, and I'm grateful that in the last year, Marcio has also agreed to take the role of chief of the Division of Endocrinology here at the University of South Dakota. He's a nice guy, a solid fund of knowledge, and a great educator. Your grand rounds last year was fantastic. So Marcio's got at least a couple dozen papers and book chapters, and today he's going to teach us about obesity. Thanks for being here.
All right, thank you. Can you guys hear very well here? Yeah? Okay. So I decided to talk about obesity because overall I don't think we do a very good job on that. We don't treat obesity as a disease, and we should. And I think our understanding of obesity also is a little bit behind. As endocrinologists, most of my patients have diabetes, and they ask me to treat diabetes, but I think also we should treat obesity. And don't forget that this is probably one of the main reasons that patients have diabetes. So it's a very interesting topic, and what I would like to discuss today is briefly about history of obesity. This will take an hour at least to talk, but I will try to talk in few slides about obesity. Then we're going to talk about how is our clinical approach to the patient with obesity and some treatment options, mainly medical treatment for obesity that we have, and that are new things over the last few years. So if you go from the evolution, we were scavenger-gatherers to hunter-gatherers to agriculturalists over time. So we went too fast to the modern society, and we didn't have time to adapt for that. So the things that we are built to do not long time ago, 10,000 years ago, now is not the same thing. Why do I say this? Because whatever we are built 10,000 years ago, where we have no resources, whatever we are able to hunt, we will eat. No, we don't need this anymore because we can just open our fridge and eat whatever we want. So we were really built to do really good absorption of the things that we ate in the past, and we don't need that. We would be very lucky if we didn't have to absorb right away everything that we eat, but we actually continue to do that. So if you think, apes, they have a large proportion of their, the way they absorb is with fermentation on the large intestine, and we, over time, increase our small intestine, where we are very good in absorbing fat and sugars and other easily digested food components. So one thing that happened over time was, and we are not sure when this happened because history sometimes we have some blanks, But at some point when we start cooking, we reduce our need for high fiber food, and we are able to absorb this food right away. It could be 10,000 years ago, 50,000 years ago, or even 500,000 years ago. But that was one of the changes. And they also believed that at that time, we start also having a large brain. So a lot of studies will link brain size with cooking, but we don't know exactly the date. So this, and if you see in just 1,000 of years, so many things change. It's not even 1,000 of years, it's probably 50 years. What we do now, we eat out. More than 30% of our meals will be eating out. Breakfast, even breakfast we eat out. 25% of McDonald's business is in breakfast. We don't realize that, but that's true. We consider food a social event. You go out with your friends, you spend hours eating and drinking. We didn't do that like 1,000 years ago, but we do this now. It's a time that you can bond. It's a social behavior to eat. So things change in just a few years, less than 50 years ago. So think about environment. How was environment 50 years ago on the 7th and how is right now? Well, transportation. We don't need to walk to work anymore. Physical activity, when we do physical activity, it's just because it's recreational. You go to the gym. Can you imagine this on the Middle Ages? Oh, I need my time. I'm going to go to the gym now. No, it didn't happen at that time. But now when we do exercise, it's recreational. We can go to any fast food. If you don't have something, you go to a convenience store and you can buy whatever you want. Cost of food, well, we have a lot of subsidies for food actually that is not very healthy. But that's the way that things are working right now. And we spend probably how many hours watching TV, movies, and things like that. So things change quite fast. So what happened is that the deposition of fat is an adaptive physiologic process of energy storage that became maladaptive when we have all these advances, because now we don't need all that energy, because we don't expend that energy. So some will consider obesity as a side effect of the evolutionary process. If you guys have a chance, I would recommend to read this book. It's very nice, The Evolution of Obesity. We'll talk about this and much more things. So it's very interesting. So briefly, what happened in the US? Well, look this. And this is not the presidential electoral map. Okay? It's just the obesity trends from 1985 to now. So if you see, most of states will be less than 10% or 10 to 14% of obesity. And this is what happened over the years. So it keeps changing. And around 2010, we have this. Most of states will have almost 30% of obesity. And if you think, look this is self-reported obesity. People, they see themselves very different what the reality is. So this is the self-report versus true obesity rates in the US. And this is just to give an idea from 1990 to 2010. So this is worldwide. It's also quite common. It's getting much more common in third world countries because they are living like we live in US. There's much more fast food and things like here. So we do have to consider obesity as a disease. If you think any specialty will have, so obesity will have consequences in any specialty. We can think about rheumatology, endocrinology, cardiology. You're going to have problems in any organ of your body due to obesity. So as a physician, we probably should consider obesity as a disease. And we have to be aware this is a physiological dysfunction, and there is morbidity and premature death because of obesity. So if you think that this as a disease, obesity as a disease, this is the percentage of patients with a BMI greater than 30. This is a percentage of patients with a lot of comorbidities due to obesity. This is patients with a BMI greater than 50. This is just a percentage of patients on medications for obesity. This is the patients that go to bariatric surgery. And this is, for example, patients with Parkinson's disease, HIV, and AIDS. So it's quite common. It's very, very common, and I don't think we actually are doing a very good job in treating obesity. This is one thing, I didn't know that not a long time ago, but there is what they call fat mass set point. And this is probably a new concept for most of you, and pay important attention because the way that we treat obesity depends on this. So let's say that you require around 1,500 calories per day to keep your weight with minimal exercise. Most of us will have at least 2,000 calories. So we are behind, we have to burn 500 calories, or you have to lose 500 calories, otherwise, technically, you'll keep gaining weight. So if you think that, if you put it in all your adult life, to maintain just 20 pounds range, or 20 pounds up and or down, you have to match, if you believe that you have to, these 500 calories, you have to match like 5 calories per day, so 0.2%. Otherwise, you keep gaining weight. And if you just, instead of 5 calories, you go to 10 calories, you're going to gain 40 pounds instead of 20 pounds. So you see, so if you believe that it's all calorie in and calorie out, if you are behind 500 calories per day, in a week you gain 1 pound, because 1 pound of fat is 3,500 calories. So this is not true. Actually, your organism will balance out your ins and outs. So it's a physiological trait where your body will find ways, hormonal-wise, to balance your calories to keep your weight on that set point, what they call fat set point. They did some studies on rats, and they show that, so these are 3 groups, one that were over-fat, the one that they let eat as they want, and the one that they restrict food. If you see at some point, even though that you keep overfeeding, and you are giving more calories and more calories, they don't gain more weight. At some point, they will plateau, and that's that fat point, that fat set point. If you restrict food, at some point you would expect that you're going to keep losing, but at some point, your body will regulate, and that will stay steady. And that's what we call the fat set point. So when we see all these studies, weight loss medications study, what usually happens? Well, patients on placebo and then medication, or they start a diet, they will lose significant weight in the beginning, but at some point, you regain weight again. Most of the time, will at least, if you keep at least a good diet or you keep the medication, you can regain, but you don't go back to normal. You still going to be below, but sometimes patients will gain even more. Why? Even though that you are doing the same thing, because of the fat set point. Your body remembers that you have to go back to what they believe that is normal, and will do some things like preserve energy to keep your weight as it was before. So that's because the majority of diets, patients will do well in the beginning, but not really later on. So what is the fat set point? Well, it's a failure of normal weight and an energy regulatory mechanism leading to an elevated body fat set point. So your body will defend this set point, and will, if you eat more, will decrease thermogenesis. If you eat less, will increase thermogenesis to keep that set point steady. So our main goal, as we're going to see down the road, is to change that set point. It's not easy, but it can happen. It's easy to change up, not easy to change down. This is very disappointing, but you guys probably remember The Biggest Loser, that TV series. Well, remember that they lost 60 pounds, 80 pounds by the end? Well, the average was 60 pounds weight loss by the end of the 30 weeks of the show. So they followed these patients for 6 years. And as you see here, let's use my mouse. The average they didn't go back to that weight, but they almost everybody regained weight after that. Even though that they lost significant weight, at some point they gained, some will gain even more, some will be a little bit less. But average-wise, they finished with 6 pounds weight loss, but they went back to 20 pounds weight loss. So most of them regained weight. That's another example of the fat mass set point where you go back where your body believes that you should be. So do you think things changed from 1970 to 2013 about our genes? Well, I think we are pretty much the same, but what changed was the environment. In 70s, just a third were overweight. Now it's 2/3 of people are overweight because there are a lot of environment things that are happening right now that are making we change our set point. And the other thing that we should be aware is this range here. Most of us will be here in the middle. Some will be here, the lucky ones, but they can do whatever they want. They can eat whatever they want. They're not going to gain weight. They are very good in regulating their set point. But some, the minority, they probably have some genetic problems where they can do eat just a little bit. If they go a little bit more than what they should, they gain weight. Maybe in a few years, we're going to be able to test these genes, and we're going to know the ones that will do good with one thing, the ones that we're going to do good with other things. But the reality is this happens. This happens quite often. So how do you change, now we're going to be kind of talking about treatment. How are we going to change body fat mass set point? Well, there are a few things that will push this set point up, like sleep deprivation, and I will also show some studies about that. Circadian, not muscle, circadian cycle, dietary choices, stress, medications. We, as physicians, will give medications that will cause weight gain, or sedentarism. So all of these can put the set point up. How can we push down? Well, dietary changes, lifestyle changes, exercise, weight loss medications, and the best one for changing the set point, and we'll show by the end, is bariatric surgery. We can try a lot of things, but nothing is going to be similar to bariatric surgery. This is the one that changed the set point the most. And some patients will require that. Maybe we are still behind in recommending patients to have bariatric surgery. So how do you treat? Usually the recommendations, the endocrinology guidelines recommendation is a stepwise approach where we start with, you see a patient in the clinic. The problem is that we don't have that time to spend half of our visit to talking about this, but first you can tell the patients to have some lifestyle changes. Then, if you're not successful with that, you may need some professional lifestyle changes. We can talk about medications, and we have good options. They are still expensive, but we do have good options. We will consider weight loss surgery, and there are other things that we can do after weight loss surgery, other procedures as well. So this is the way that we're going to do it. So the first thing seems to be easy. We know what to do, but it's just difficult to do. So you can address all these things here, and I will talk about some of them. For example, diet. So they are talking about 4 different diets. So you see one is 65% carbs, there is the other one that is 35% carbs. As you see, all of them will work pretty much similarly, okay? Not significant changes. And most of them, as you go those 6 months, you lose the most, and then after 24 months, you regain some weight. You don't go back to baseline, but you regain some weight. So different diets, very similar. You can see here Atkins diet, Zone diet, Learn program, Ornish diet. All of them you're going to see majority of patients losing 5 to 10% weight. And then we have the extremes. Some lucky ones losing 25 to 30%, and some actually gaining weight. And it's not very different among diets. It's just the way it works. Maybe in some years we're going to learn the ones that will do better with this diet and the other ones that will do better with the other diet. Maybe genetic tests will say that, but for now we still don't know. So the way that I would approach that is, see, most patients, when you see them, they tried in the past, they lost some weight. So you may have to ask them, what did you do? How did you lose that amount of weight in the past? And maybe that's something you should try to mimic. For me, I see patients with diabetes. If I would recommend a diet, I would recommend a diet with low carb. I think for me it's very important because besides treating the obesity, I will treat diabetes. Low carb diet is great for diabetes. Some patients may not be the best option, okay? So here,
I don't know what happened. Let me check. It went down spontaneously. I don't think you were clicking anything, Marcio.
No, I didn't click anything.
Your slides still show.
It's here. Let's see if I can do it again. No, it does not.
Okay. I'll be right back.
Okay, you can stop and ask some questions.
I'll go, yeah, why don't you?
Well, any questions so far? Yes.
So has the set point of people changed in so little time?
Yeah.
Like
Yeah.
1,000 years?
Yeah.
This is not genetic. It's
No, the set point. Well, the thing, if you see, so that slide that I show you from patients in the 70s and patients now, where just a third were obese, and now because what happened probably? It's not a genetic. We have. It's just a short period of time to have so much many genetic changes, correct? So what happened was environment. Environment changed the set point. Well, lack of exercise, because in the 70s probably we were doing more things than we do now because we don't need to do it, and the food. And I will talk about portion size and things like that. So this is slowly will change the set point. And then you have a new set point. There is a lot of life events that will change set point. For example, you had a knee problem, you used to exercise a lot, and you are not able to exercise anymore. So, and you say months not doing exercise, you keep doing the same thing, you have significant weight gain. After you have a baby, a lot of patients will gain weight because of that. Menopause is a time that you have lack of estrogen, more fat deposition. You can change the set point as well. So there are a lot of things that will change set point. Or you got sick in the hospital, or the physician started you on steroids, and you are on high dose of steroids, you gain 30 pounds, now you're behind. So it's very easy to change the set point up, not as easy to go down. So
you mean that even if whatever changed the set point goes away, like your knee gets better or you finish your steroids, now for every amount you eat, you will tend to gain more weight?
Yeah, because you not more weight, but you're gonna not that you're gonna keep gaining more weight, but that's the new set point. So the energy balance will try to keep, even though that you eat the same thing, you keep that weight. You know, even that you do less calories, at some point you lose and you go back. That's the way it works. Okay, so this is just an example of the diets that we have. The Atkins diet is very low carb, and there is Ornish diet. It's a lot of carbs. So there are different diets that we're not going to talk specifically about each one. But so what do you think it works then? Why some people go to that extreme and other will even gain weight? Well, one is genetic. So some patients do better with some diets than others, but the other one is compliance. So this study actually show if this is a number of just a higher number, better compliance, where you can see patients losing much more weight if they can keep the diet. The problem is that some patients will do diet for 1 or 2 days and they don't like that kind of diet and they just don't keep doing. So compliance is big. If patients can stay on that diet, they can keep losing or at least plateau and not regain. So diet compliance is important, and you're going to have to ask the patients about that. This is just another example where you have the extremes. All different diets, most patients will lose some weight, and you have the extreme here, 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 and then you have the extreme of patients even gaining weight. So it's really not about one diet. It's about what is the best diet for that specific patient.
How does the profile diet compare to these?
Okay, so the profile diet, you're gonna substitute, correct? You have your meal, and they will say, okay, you're gonna take that shake, and then you're not going to have. So that shake is going to be higher on protein and not a lot of carbs. So that you're going to see also the same curve. It doesn't matter the diet. So some patients, I see patients doing profile diet that they lose a lot of weight. And then at some point, they cannot keep doing because it's difficult. Remember that fat set point. You lose that weight, but then your body will adjust, will make you hungry where you want to eat, and you just cannot keep doing. It's any diet. If you have one diet that really works, that person will be billionaire, correct? Everybody will be doing that diet, and everybody will be, we wouldn't need all different diets. I put it this way. Briefly talking about portion sizes, it has changed over time. There are a lot of studies showing that if you have a larger package, you're going to eat that. And you're going to gain weight because of that. And a lot of people will believe, well, if that's what they serve me, that's probably right. I'm going to eat that. It's good. It should be okay. And look this. These are things that change over time. We have drink-wise. Do you imagine drinking 64 ounces?
Which one is your 500 calories? Which one?
Well, how about, so I think around 12 ounces is probably more than 100 calories. I think it's between 100 and 150. Do the math.
So the big gulp is your 500
It's more than 500. Probably more than 500. Yeah. These are two recent studies, and it's very, I would say, problematic. Don't you believe that drinking diet soda is great? That you're not going to gain weight. It's just keep drinking. You can have many. Well, that's a Canadian journal that showed. I don't know if you're going to see one. This is RCT, and the other one's cohort studies, actually showing. This is a BMI. So actually, cohorts showing that drinking diet will increase your BMI, and weight gain also with that diet soda. So there is studies showing that even though that you go to diet drinks, you keep gaining weight. Okay, so yeah, if the patient comes and asks me, is diet okay? Be careful what you want to answer, because studies are showing actually that you may gain weight. The worst is from this one that came on stroke like 2 months ago, where they checked the sugar and artificially sweetened beverage and the risk of stroke and dementia. No change in stroke and dementia with the sugar drinks, the regular increased risk of stroke and dementia on this prospective cohort study from Framingham on the artificially sweet beverages. So there is increased risk as you go with more drinks. They separate here by 0 drink per week, 0 to 6, and more than 1 per day. There is a statistic difference about increased risk of stroke and dementia with diet. So let's talk briefly about behavior. Well, we always have healthy choices and a healthy environment. It wouldn't be nice if you always have healthy food, watch portion size, cook more, eat only when you're hungry. But what happens is we have a lot of food, snacking, convenience stores, vending machines, processed foods, cooking less, eating out more. We have large portions, fast food choices, value meals where you can eat whatever extra, and food carts and all-you-can-eat buffet. So this is our environment, and it's very difficult to change that, unfortunately. We used to walk more stairs, park the car far away, be more active, watch TV less, but what we are doing is we have elevators, escalators, telephones, remote controls, cars, computers, emails, drive-through, TV, cable, video games, homework. Everything is against us. I'm not saying that this is bad. I mean, it's great. But we, evolution-wise, it's too fast. We are not ready for that for the reasons that I mentioned. But, I mean, it's good, but it's bad. That's what they say, that it's a side effect. The obesity is a side effect of the evolution or the technology. Activity. It's not about calories in and calories out. I told you before about the fat set point, But there is it's a combination. There is hormones involved on that. So don't believe that, okay, 500 calories today, exercise, I'm losing 500 calories there. It's not the way that it's going to behave. There is a lot of studies showing that muscle mass is very important. You can think like if you have more muscle mass, you need more calories to keep that muscle. So maybe you'll be allowed, you need to burn more calories in your basal energy during the day. So there are a lot of studies on that as well. So these studies are the same example of diet. They did this physical activity where patients with 600 calories, 400 calories, and all control. Look what happens. We have patients doing 600 calories, so aerobic exercise, and this is the way that they lost weight. Some lost a lot, some gained weight. Even with a 6-calorie session, 4 calories is pretty much the same thing, and even the control, we see almost the same curve. So don't believe the calories in is the same of calorie out, because it's not. If you tell the patient, oh, if you do 200 calories burn, you're going to keep losing weight. Well, studies are showing that that's not true. You may lose some weight, but again, you want to go back to your fat set point, and at some point that amount of exercise will make you not lose that weight for many reasons. Hormonal, or you're going to end up eating more because you're going to be hungry and things like that. And one is, it's clearly as we get older, we lose muscle, we gain fat. So we have to keep this in mind. And not just, when you recommend a patient exercise, probably not just aerobic exercise. So weightlifting is also important because you want to have that muscle, even though that you lose muscle, if you keep doing exercise, you gain muscle over time, okay? What about sleep and the circadian rhythm? Well, there is also a lot of change, hormonal change. It's thyroid, it's growth hormone, cortisol, and the studies are showing that patients, I missed the lower part here, but patients with less than 5 hours of sleep per day, they will gain weight. There are a lot of studies, these are meta-analyses showing that. So sleep deprivation will cause weight gain. Night shift work, if you work nights, also there is a lot of studies, and this is another meta-analysis showing that you gain weight. Clearly, it's very common to see weight gain in patients with night shift. This is, I saw that, I think this is fascinating, that they did this study in patients with overweight and obese women, where they did the same calories. The majority of the calories were different times of the day, one in the morning as breakfast and one at night, and you can see the ones that had the majority of calories, even though that they had the same calorie amount in a day, they lost weight. The ones that ate in the morning, the ones that ate at night, gained. They had less weight loss. So the time of the day that you eat, it seems to be, there are a lot of studies showing that as well. So it's not just one thing, it's a connection of a lot of things. It's the diet, it's your lifestyle and the kind of activity that you do. All this putting together, you should be able to successfully change your set point. It's how much you can change the set point. The set point varies patient to patient, person to patient. Now, from our standpoint, what do we do for the patients? Well, we cause weight gain, and sometimes we don't realize that. There are these medications that will cause weight gain. Endocrine, a lot of medications will cause weight gain. And then there are some that we even don't realize. I had a patient that asked me, I saw a patient for weight gain, was obesity. Weight gain 20 pounds, 3 months. And couldn't figure out why. Then you go to her medication list. She was started on, I think, I don't know if it was atenolol or something like that. She gained 20 pounds in 2 months. It was exactly the time that she started the beta blocker. We stopped that. I saw her a few months later. She lost. She is the extreme, correct? Most patients will gain a little bit. But we have this genetic change. Patients, there is this predisposition. Some will gain a lot. And it happens, so pay attention. Beta blocker causes weight gain. So this is an average, what you can expect of weight gain of these medications here. And some will actually cause weight loss. average-wise. And we'll talk a little bit more about some here. For example, here, weight loss. I don't treat these, I don't use a lot, it's not part of my practice, but these medications will cause some weight loss. The ones that I use, and I'm trying to use less and less, is gabapentin and pregabalin, because I use for neuropathy, and it causes significant weight gain. It's almost everybody will have some weight gain on these medications. And these are other ones that will probably, yes?
Are these medications resetting your set point?
Yes,
Or
yes.
Or is that's just as a side effect of the drug, as soon as you stop the drug, you can expect that they're going to lose weight?
Yeah, you will, if you stay longer, it will change your set point. For example, the patient that I gave as example, obviously I told her to make some change on her lifestyle, but in a short period of time, because she was not taking for a long time, she lost almost all the weight. But if you stay long enough, like prednisone or things like that, will change your set point. And it's going to be harder to lose weight. It's always harder to lose weight than gain. So for diabetes, what I do on my daily basis, well, patients on insulin, if you have to choose, if the patient needs to be on insulin, a long-acting insulin will cause less weight gain than a short-acting insulin for sure. Like Novolog will cause more weight gain. So I avoid to use the short as much as possible. I will start a long-acting insulin. Usually, long-acting insulin is never the best option as a single agent, so we're always going to do a combination of more agents. So metformin is always the first option. We will see that we can cause some weight loss for that reason. I like GLP-1 agonists, one of the ones that I like most. We see some weight loss because we'll decrease your food intake. There is this early satiety. Some patients will have even nausea with this medication and decrease the appetite as well. So this is a great medication to use with the long-acting insulin. Now, for the last 4 or 5 years, we have the SGLT2 inhibitors that make you pee sugar. You lose 300 calories per day just with this medication. We have 3, Invokana, Farxiga, and Jardiance, and they are great medications for diabetes. It causes weight loss as well. So here is just for you to have an idea about the percentage of weight loss or weight gain that you can get with medications for diabetes. So keep in mind when you treat patients with diabetes. Regarding depression treatment, well, bupropion, and bupropion is even part of the medication for weight loss, and we'll briefly talk about that. So bupropion is a good medication. Most of it will cause some weight gain. Most will cause some weight gain. And mirtazapine will cause substantial weight gain. So keep that in mind as well. So when we talk about the fat set point, our old way to think will, well, less calories, you're going to have the weight loss and you'll be okay. But what happens is less calorie, we have short-term weight loss, your set point is not changed, and you're going to do a compensation, or your body, or you're going to get tired and you have to eat more, or you're going to do less exercise, and everything goes back and you have this weight regain. So what you're going to do is change the way that you do the things. With food, if you do food change, well, you're going to find a specific diet that you can stick to that diet. I'm not saying that you have to stop eating, but eating healthy, and over time, we should be able to change the set point. And you're going to add sometimes no, you're going to add exercise, and you discuss a combination of aerobic with anaerobic. You're going to change, you're going to see with the patient if there is, most of the time the issue is not even what they eat. I understand, I see a lot of patients saying that, oh, look, I don't eat. I understand that. Probably you eat a little bit more than what you think. That's true, but probably there are many other things going on, and usually it will be lifestyle. Or the patient has a lot of stress at home, increasing cortisol, weight gain, or you're going to have working at night or other problems. So there is always reasons for weight gain, and we are missing that. We have to ask the patient, and you'll figure out that. So let's talk briefly, last part here, about treatment for obesity from our standpoint. This is just an idea where these medications act. We have very good options. Unfortunately, they are still expensive. but they are good options. So the cheap one, phentermine, you're supposed to use for a few months. Will cost probably 3 to 4 kilograms. We don't use this here. This you probably know. We're going to decrease absorption of fat, correct? Then you have Belvic, Simia, Contrave, and Saxenda. For example, Simia, a combination of phentermine with topiramate, and they cause, the combination of medication causes significant weight loss. Contrave is a combination of bupropion, the antidepressant, with naltrexone, and also causes significant weight loss. Saxenda is the Victoza. It's a GLP-1 agonist, but it's a higher dose. You titrate up. So usually we do up to 1.8 in our patients, and this is up to 3 milligrams, and they all will lose weight. Some of the side effects should be aware of on this medication. Usually they can tolerate quite well. The main problem is price. Just to have an idea, I think this will cost more than, some could be even thousands, 1,000 per month if you pay cash. It's difficult to say, to tell a patient to spend $1,000 on a weight loss medication, right? Here is just an example of the phentermine and topiramate, comparing with just phentermine and comparing to combination of the weight loss, so significant weight loss here. Belvic, this is a meta-analysis of these both studies showing the weight loss is significant, and all other markers also improve with this medication. Saxenda showing also good weight loss, good profile of weight loss. That's one of the reasons that I try to do GLP-1 agonists when I treat diabetes, because patients will end up losing weight, for sure. This is Contrave, the combination of bupropion and naltrexone, also causing weight loss. 50% of patients will have a 5% weight loss in this patient, in taking this medication. So this is just to have an idea what we can do. Well, I think you can do diet and lifestyle change in these patients, okay? Initially, they may lose some weight, but then to lose more than 5%, you probably will have to consider more than that. So you're gonna have to treat with medications. When you are at more than 15%, obviously you guys saw the curve, some patients will lose just with diet, but the majority will not gonna be able to lose 15%. And that's when you when I start considering more surgical interventions that will be very effective in the majority of the patients. So it's not, I briefly will talk about bariatric surgery because we can refer patients to bariatric surgery, and we probably should refer more. It works very well. In the past, we thought it was just a mechanical thing, correct? You restrict food intake, you have more absorption, you lose weight, less calories, calories in, calories out. Well, it's not like that. It's much more. It's physiological. There is a lot of change from the GI system to the brain that will cause the weight loss. You can't believe. I see most of, when you're on call, we almost see all patients after bariatric surgery, and they have the surgery. The next day, they ask us to give recommendations for diabetes. Most of the patients will not going to need to be on medication. They were like high doses of insulin, and you go there and they are not requiring anything, or 20%. But they still have the same weight. But just the surgery changes the hormonal things that we still don't know a lot of things, but that will cause the weight loss. So it's more than just a calorie restriction. And that goes along with the fat set point that we discussed before. These are some, majority of patients will have this liver gastrectomy or Roux-en-Y gastric bypass. The one that is 2%, the biliary, the duodenal switch it's very complicated. We don't do a lot, and the gastric banding also, we are doing less and less. So majority of procedures will be close to. And then this is the Swedish obesity study where they show the weight change with this. It's significant. It's at least 15%. If you do the Roux-en-Y, you have 30% weight loss, and that's amazing. And you see, you keep your weight. Yeah, I mean, you lose more, obviously, the first year, but these patients keep that weight for 20 years. So it really, really works. So because this changed the fat set point, remember, it's not calorie in and calorie out. Why? How can we prove that? Well, almost no patients will go underweight. If it was just a calorie restriction, we would expect, well, not eating, at some point you become underweight, correct? Because you're eating much less. But it's not true. At some point you go. That because it changes the fat set point. Patients that get pregnant, they gain weight during pregnancy, showing that it's more than calorie restriction. There is a study on animals that's showing that even if you do bariatric surgery in thin patients, they don't lose weight. The bariatric surgery changed the set point. It's much more than calorie restriction. Okay. This is just another example of things that will change with the bariatric surgery. This is a Stampede trial talking about diabetes, bariatric surgery and diabetes. What is the best treatment for diabetes? Unfortunately, it's bariatric surgery. It's not medications. I mean, these patients will fix their diabetes. Sometimes they are on a high dose of insulin, and a few months later, they don't need anything. Or if they need, they will definitely require much less insulin than what they were taking before. So this is proven in studies with more than 5 years of follow-up. Okay. So I just want to add one thing here on the stepwise approach. New things coming is the endoscopy treatments. GI will be doing more and more over time, where they will do even surgeries endoscopically, where they add devices to decrease the size of the stomach. They will do surgeries internally where they will decrease the size. They will bypass things. So there are a lot of things coming. It's not the scope of this presentation, but there are a lot of things from the GI perspective that is also happening here. With that, I think we have some time to answer some questions.
Can you talk about short-term versus long-term things affecting the fat set points? Mm-hmm. What would be like an example of short-term versus long-term affecting that? Like time range?
Sure. I think short-term, if you can find or pinpoint a reason for that weight gain, and you can take that out of this of the thing, I think that will fix the problem. I gave you the example of one specific medication that was just started. Maybe example of the knee surgery, and the patient is back. So if you don't give enough time to change the set point, you probably can recover that set point faster. Okay, but over time, if you just keep adding things on the set point, then it turns out to be more difficult.
So would it be like even a couple of weeks, 2-3 weeks to even change that, or is that
I don't think we can answer that. I think it changes patient to patient. I mean, because we have all these extremes, correct? Majority of patients probably will be a few months, but there are some that could be weeks and some will be years because everybody responds very different. Yeah, so it's difficult to say exactly.
There is a television program on cable 66 where they discuss a lot of health issues. And periodically they will discuss, they have a program called My 600-Pound Life. What in the world is going on with, and they're pretty much women, occasionally it's a guy, but what is going on with people that get up to 600 pounds and beyond?
So if you think like that, if you have 600 pounds, how much calories do you need just to keep that weight, correct? It's like, I think, I don't know if I saw this program, but I saw patients eating like more than 10,000 calories in a day. It's impressive, but they have, yeah.
I mean, these people must have a lot of enablers around them because they're too big to even get to achieve.
They stay on their bathroom. They don't go out. I saw that if they have to really move, they have to. Somebody needs to come and
Bring them the ice cream.
yeah.
Can you say a little bit about fatty liver disease, unless I missed it when I said
No, I didn't talk about that.
So clearly the rate of NAFL, non-alcoholic fatty liver disease, must be going up. I'm wondering if NASH, non-alcoholic steatohepatitis,
Mm-hmm.
liver failure is going up.
Yes, it is going up, and yeah, it is much more common now. They do recommend, the first screening with change in the AST and ALT, correct? And you do the ultrasound, and you're gonna see that it's much more common than before, and it's trending up.
And Hisham, I'm the hepatologist. Even with the AST/ALT being normal, it doesn't rule out fatty liver disease. Indeed, the Dallas study showed that 79% of fatty liver disease patients have normal ALT. So,
So when would you look for NASH? When they have other obesity-related,
So if
just
they have-
metabolic
yeah.
traits like low HDL?
if they have risk factors for fatty liver disease, diabetes, and high BMI and other things, then if the liver numbers are normal, then sometimes they do ultrasound for whatever reason, and if the ultrasound is showing fatty liver and they have it, if it doesn't show it, then doesn't necessarily rule it out, but I don't think we need to keep digging in. I mean, if the ultrasound is normal, AST/ALT are normal, in someone you are not expecting to have liver disease for whatever reason, based on your physical examination and history taking, to have any signs or symptoms or lab values to suggest liver problems, especially thrombocytopenia, I don't think we need to keep digging in. But we see a lot of patients, as you said, a lot of patients now coming to us with fatty liver disease, sometimes even advanced phase. We have people who are diabetic presented to us with liver cancer because they have NASH, cirrhosis, undiagnosed, and now they came with liver cancer.
So you screen with ultrasound and a subset of your kind of
I do.
tie-in?
Well, I guess we probably should start thinking about this,
Yeah.
but on my daily practice, no,
Yeah.
I don't do that.
I guess it depends on risk factors. Maybe one more question?
Yes.
I've seen some stuff on cyclic fasting. That's kind of a new fad now. Either every other day
Mhm.
or limiting your intake for only 8 hours a day. Do you know if that helps reset that fat set point, or?
I don't know. I know what you're talking about, and I know that there are even books talking about that. I don't know about a lot of evidence. Still, maybe there is, but I'm not aware of that. But I know that some people are doing that, and there is some rationale for that.
We should
There is
look.
things about microbiota as well.
Yes.
They're studying a lot about that. I think they are earlier stages, but I think this will develop over time. They are even doing transplant of microbiota, but I don't think it's working right now. But there is a lot of evidence that is going to be coming in a few